So good morning, everybody. And again, thank you so much for having me today. And again, a special shout out and thank you for AIM at Melanoma for putting this wonderful Saturday morning conference together. Again, my apologies that I can't be there with you directly in person as I had a conflict, but again, very excited to be here today and to provide a very small overview of leptomeningeal disease to all of you. And with this, I'll just get started. And again, I hope you will find this useful. So really, again, what I will try to do over the next 20 minutes, and most of you might know me, I'm Bella Glitza. I'm one of the associate professors at MD Anderson, and I do specialize in leptomeningeal disease in patients with metastatic melanoma. And these are my disclosures. And to really just move straight into kind of what I'm trying to accomplish today is really familiarize all of you with what leptomeningeal disease is, how often do we diagnose this, how do we diagnose this, and what are the currently available treatment options for these patients. And again, I know that some of you might be experts with what we call LMD. Some of you might have never heard of it. So I kept it a little bit simple. But again, my goal is that you all will walk away after these 20 minutes and have a better understanding of what this actually entails. So I would like to first get started to talk a little bit about the anatomy and what is leptomeningeal disease. And I will refer to this throughout the talk as LMD. And so maybe the first comment I would like to make is that leptomeningeal disease is not specific to melanoma. It can actually happen from any tumors, also leukemias and lymphomas. And what it really just describes is the place of the metastases or where the cancer has actually spread to. And I thought it's important to maybe show you kind of a little graph and kind of actually can explain what are the meninges. And this is a snapshot kind of out of your skull and your brain. And you can see we start off with the skin, and then we have the skull, then we have something called the dura, then the arachnoid space, which also then has the CSF right there, and then the pia mater, which is the skin that lies right on top of the lining of your brain. And then you have the brain, kind of the meat of the brain right underneath. But these structures here, the dura, the arachnoid, and the pia form the meninges. And again, the arachnoid and the pia mater then form the leptomeninges. And as you can see in this little graph, this round little larger red ball, it's supposed to be a brain metastasis. So that sits kind of in the middle of your brain or in the meat of your brain, versus a leptomeningeal metastases is the cancer really kind of made its way like right between the pia mater and the arachnoid. It's sitting or is being kind of bathed in the cerebrospinal fluid, which we call CSF. So very different in regards to location compared to what we call a parenchymal brain metastases, again, meaning it sits in the meat of the brain. And again, this process can happen anywhere in your brain or in the lining of your brain. It can happen inside of what we call the ventricles, those fluid-filled sacs, because now that you kind of can see where those metastases sit and how they're again bathed in the CSF, they can travel down all the way around to the spinal cord. They can travel inside of these ventricles and form tiny new colonies throughout. So again, leptomeningeal disease is a description of where the tumor cells made it, where they formed metastases. And on the right side, we have a quick picture of how these cells can actually get into this particular leptomeningeal space. And there are various ways of how tumor cells can get into this. Again, obviously, if they develop blood supply, they can get into the arteries or into the vein and then kind of seep out and crawl out through those blood vessels and then form again new colonies in these areas. Also not hard to imagine if you have a tumor that sits right under the meninges, tumor cells can kind of crawl through those barriers and get into the CSF and float again around. And sometimes what happens is also if you have a resection of one of the melanoma metastases in your brain, if the tumor would kind of spill open, leptomeningeal disease can also develop because there's spillage into the CSF. But again, this is the most rare form maybe of how LMD is actually again developing. So just as a quick overview, what this actually means and where this happens. But if you think about now that I'm showing you this little dot again, and this is larger than what we typically see, it also will be very clear when I show you some pictures or talk about diagnosis, how LMD can actually be very, very difficult to be diagnosed because, again, it's not this big blob that sits within your brain. So talking about how do we diagnose LMD. And so I threw up a few patient pictures and again, trying to explain how different things can look like in each patient. And so these are all real patients of mine. And again, you can see kind of here in patient A, this little fluffiness that you can see in the back of the brain. This is all leptomeningeal disease. And so the cancer really kind of, the way I sometimes also describe it, if you think of your brain as a walnut, we took the skull off, meaning we took the shell off, and now you're looking at the nut in front of you and you have this thin lining or the skin of the walnut. It's like somebody put powdered sugar on top of it. Those are your cancer cells. And this is how it looks on the MRI. And again, we slice the nut, right? And we look at kind of the foci and the cell site. And so this is, again, LMD kind of in that particular area. This patient labeled B, it's a very different type of LMD. This is, again, the coating. If you can see kind of those black holes, those are called the ventricles. This is where the cancer cell kind of coated themselves from the inside out, if that makes sense. So this is kind of an intraventricular LMD. Patient C, you see the errors. It's very, very subtle. It's, again, just this thin little line on the siding of the ventricles. Patient D has more nodules inside the ventricles, and patient E, which is extremely hard to diagnose and was very challenging to diagnose. Even though those white little lines look like, again, it's kind of the coating, the powdered sugar, it's actually a good amount of these are blood vessels, but some of this actually represents LMD. So the mainstay of diagnosis is doing an MRI brain and spine. And I didn't put up here any specific spine MRI pictures with LMD. But again, remember, it can kind of happen anywhere along the brain and the spine. So brain and spine MRI is absolutely important, but then also something called the CSF analysis. And we get the CSF through a lumbar puncture. So patients are either sitting down and kind of bending forward or laying on their side. And we get a little bit of the spinal fluid out of the space. And what we do, we put it under the microscope and look for those cancer cells in there. However, it's not very sensitive, meaning that even if it's negative, if somebody has MRIs like this, we can still make the diagnosis based on the MRI only. And sometimes we need to repeat it multiple times to really make the diagnosis. But again, sometimes we don't go over and over doing lumbar punctures because they can be uncomfortable for the patient. Now, how often do we see LMD in our melanoma patients? Well, this is from a paper published a few years ago, and I would say it's maybe quoted a little bit too high, but bottom line is while melanoma LMD is not common, it's not that uncommon. So if we think about how often melanoma loves to go to the brain, which you heard earlier today, melanoma just loves to travel to the brain and form new colonies there. And it's also the cancer that probably forms most often leptomeningeal disease. Now, again, I don't think we see this in 46% of patients with stage 4 melanoma, but I would say that we see it in probably 10 to 20% for sure. And what are some of the hallmarks? We often see it later in the disease course. So a minority of patients is being diagnosed with LMD early on. It's typically something that happens much later in the journey of a patient's disease. In most cases, we actually also see concurrent brain metastases, meaning, again, those metastases that are in the meat of the brain. And again, unfortunately, we have seen that LMD is rising across all tumor types, lung cancer, breast cancer, head and neck cancers. And one of the reasons, or a few reasons, might be that we actually just look more carefully, so we have improved detection. But we also know that sometimes late complications are, if we had a good control of the disease for many, many years or months, sometimes the cancer finds a way to escape and find a new place to form colonies and become resistant. So what symptoms are we looking for, or are we always, very, very listening careful to our patients? And so it's a variety, and some of them are very non-specific. So a headache can obviously also happen with parenchymal brain metastases, again, when they're inside of your brain. But most common, what we also can see is, again, double vision. Patients feel like they might have like water in their ears or have been in the pool and they just can't clear kind of this hearing loss. Again, sometimes just not seeing very well anymore. And if we have disease in the spine, not surprisingly, it can cause issues with walking, just instability of the gait. But sometimes patients also say, I don't feel I can go to the bathroom anymore, or I don't feel when I have to go to the bathroom, or when they wipe themselves, that they say, it doesn't feel the same. So again, various of symptoms, and just because you have one of these doesn't mean you have LMD, but again, please talk to your doctor so we can order the appropriate scans and assess you for leptomeningeal disease. Now, Unfortunately, we need to talk about prognosis and what is the historic perspective, meaning, has it changed over time? Have we actually made improvements in the outcome for our patients? And again, this is all about our patients. And we looked at data from patients, 178, which really was the largest number ever looked at, of melanoma patients, all seen at MD Anderson between 2009 and 2015. And you can see that the median overall survival was only 3.5 months. So really very, very discouraging. And again, very poor prognosis. Now, there were other articles published subsequently in other centers. Again, overall, very small numbers compared to what we had reported in the past. But you can see, really, again, not great outcomes. We're talking about weeks to a few months. And this even included some of the most up-to-date therapies that we included. We just looked at a new cohort. So this is not overlapping. These 172 patients that we looked at right now are really a cohort of patients diagnosed between 2015 and 2020. And we looked again, has it changed? And you can see, unfortunately, not that much. But I can share with you that some of the newer drugs do absolutely make an impact if the patients can take them. And intrathecal therapy, meaning we put therapy down the spinal fluid, also has an impact and nearly doubles the survival. And again, some patients can achieve long-term survival. And we will present more data at the conference, the European Cancer Society conference, actually in a few weeks. So what are the treatment options? And again, I will try to keep it somewhat simple, but I wanted to talk to you all about the different buckets. So when we talk about systemic therapy, that means something that we either give by mouth or by vein. So immunotherapy is typically given by vein. And we have two large options, or two big categories. The one is the combination immunotherapy with ipilimumab and nivolumab, or just using single agent pembro or nivolumab. And again, I can tell you, unfortunately, we have not seen excellent outcomes with either one given by vein, and only a minor or very small number of patients even might have any benefit from it. Targeted therapy, this is typically our BRAF/MEK inhibitor for patients that have a BRAF mutations, or pills. And chemotherapy in general has not had excellent outcomes at all, but I do like to put it up here because it's still used on an infrequent basis. Now let's switch about to another big treatment options called radiation. And so there are various types of radiation that are being used. Whole brain radiation being the most common one, where we radiate the whole brain, typically with with 30 gray. Stereotactic spinal radiation is when we target some of those nodules in the spine, especially if they're causing issues. Stereotactic radiosurgery, or what people typically refer to as gamma knife, focal brain radiation, not often used, again, because it's such a diffuse process, but again, an option for some. And I wanted to really share with you some of the newer, really investigational radiation types that we use for LMD, called craniospinal radiation, and that will be on a subsequent slide. And then we'll talk about intrathecal immunotherapy, again, putting immunotherapy down the spinal fluid through something called an Omaya, using chemotherapy intrathecally, again, really never used in melanoma at our center. And then again, some of the newest investigations using radioactive isotope, putting again an agent that can radiate kind of from within the spinal cord, but again in the brain, but very, very preliminary data only available. So let's kind of go back to systemic therapies, either pills and veins. And so we had published patients specifically with targeted therapy, a case report again that we used. But the problem is, again, what if you had already been on this targeted therapy and then you develop LMD? Bottom line, it's not going to work. But some of the things that we're trying to use to overcome this, what we call resistance mechanism, is an ongoing clinical trial here at MD Anderson using a high dose of encorafenib with binimetinib, or combining targeted therapy with immunotherapy. And again, maybe investigating some new drugs that can just make it into your brain and spinal fluid at a much higher level than the agents that are currently available. Immunotherapy, I briefly mentioned, again, really just case reports. One drug, meaning just Nivo or Pembro, is probably not enough by itself. And the trials that have really looked specifically at, again, immunotherapy in melanoma patients really weren't the blockbusters when given by vein. And again, chemotherapy has not been very encouraging and disappointing altogether. Radiation, again, a very, very simple overview. So whole brain, again, is typically given over 10 days, 30 fractions total, does not seem to improve overall survival, but can help with some of the symptoms our patients are experiencing. Maybe it is beneficial if you continue this together with immunotherapy. And again, one of the problems with whole brain is you can only do it one, you can't do whole brain over and over. Focal radiation, this is a little graph I wanted to show you. It's when we use very, very selected patients only and really trying to target the tumor with all those rays that are coming kind of from all the different sides. So the radiation that is passing to the brain, to the healthy brain, is very little of each of these rays, but they all get bundled in the tumor. And again, this is something that our radiation oncology colleagues can do beautifully and target the tumor. But again, it's very hard and very used for LMD. But again, I wanted to bring it up there that in some patients, this is an option. Craniospinal radiation, like I mentioned, is the newer thing that we're investigating in leptomeningeal disease. It's typically been used in children. And I wanted to kind of show you why this is something we might use in the future. And again, I want to be very careful with my words, is still under active investigation. But just a few words of what is proton versus regular X-ray photon. So this is a graph that uses conventional radiation, including whole brain. And you can see, and I'll try to explain to this green here and this blue in the body of the patient, meaning that the radiation, when we aim it at the spine, is still traveling forward, meaning some of the organs are being affected and can cause esophagitis, swallowing issues, or GI upset, or issues with your bowels, just an irritation of the body. However, when we use proton, you can see that this radiation really doesn't seep as much into the rest of the healthy body. There's now clinical trials that have been just reported at this year's ASCO, which is the largest cancer conference in the world. And what they looked at, again, was a small study, again, very small numbers, and did not include any melanoma patients. So again, I want to put this under a lot of ifs and buts. But again, it showed that the overall survival using craniospinal radiation with proton therapy improved the median overall survival in these LMD patients with breast or lung cancer from 6 months to 9 months when using conventional radiation. So this is something, again, that we're looking into. And again, I just wanted to provide you also with a quick, what are the newest things that we're looking at in 2022. Now, let's switch to intrathecal nivolumab. And again, this is something that is very interesting and that we've done at MD Anderson now for a few years. And again, I'm realizing I actually moved my slides around. So I'm still going to start with intrathecal nivolumab. And what it is, we're just putting immunotherapy down the spinal fluid. And I'll show you on the next slide the little Omaya that we're using to do this. It's like a port. And this was a first in human trial. Again, typically nivolumab is given by vein, but we thought maybe putting it down into the spinal fluid, it will increase the amount of drug that is in the spinal fluid. And maybe this is going to help the patients actually getting a response. And so right now, based on 38 patients that we have treated, we have increased the overall survival to 25 weeks. Is this a blockbuster? The answer is no, but and this is a survival curve. You can see that some patients have been alive for years now. And this is even in patients that had prior nivolumab by vein. And then we added, so to speak, the intrathecal nivolumab, and they continue to be alive and well. The other maybe take-home message is that this has been an extremely safe regimen to use, so we haven't seen any unexpected side effects. We have combined it in together with targeted therapy, and even at the various dose levels that we use, we have not seen a significant increase in side effects. And so again, I apologize that I actually managed to mess up my slides a few minutes prior to taping this. But again, intrathecal therapy, as you can see, we use this little port called an Omaya. We inject the immunotherapy straight into this. And again, I say this with pride and gratitude to my mentor, Dr. Papadopoulos, who trained me many years ago. We really use this at MD Anderson. This has been our mainstay of treatment for LMD for many, many decades. Initially, we used interleukin-2, which is an old immunotherapy drug. For many years, we had nothing but interleukin-2 or IL-2. Treated way over 150 patients with the approach. And again, it was our first idea that actually a small set of patients can benefit from this treatment. And then, of course, again, as we had nivolumab becoming available, we developed this trial that I just shared the results with you. And again, The interim analysis shows a median overall survival of 25 weeks. And again, the interesting and amazing part is that some patients have actually a much longer survival, now really lasting for years. The other thing we have started to do, and we are waiting for a new clinical trial to be opened at MD Anderson, is actually not just putting immunotherapy like IL-2 or nivolumab down the spinal fluid, but actually using the patient's own T cells down the spinal fluid, with the thought that we just might need to increase the amount of killer cells that are within the tumor. And so this is something we're actively working on. We've treated 2 patients thus far, and again, more to come into the future. And again, chemotherapy and melanoma LMD, very unimpressive and typically something we don't use. And the reason why I put those little graphs of a mouse brain and a human brain down here, because obviously we also tried to investigate LMD in the mouse before we put it into patients, but you can see the challenges just from the sheer size of doing intrathecal injection in a mouse versus a human. And so maybe to close off with a few things, and this is really more philosophical and why we really need to continue to push for our patients. So again, in summary, why is LMD so hard to treat? And again, when I think about my patients, again, patients typically develop this later in the disease course. They had exposure to many drugs already, so what else can I actually use to treat it? And again, is it maybe by using the same drug but putting it down the spinal fluid like we've done with the IL-2 and with the nivolumab? How about resistance? And again, performance status. I shared with you that a good number of patients unfortunately has severe symptoms or develops symptoms very rapidly. And again, performance status is a huge issue. LMD, again, remember kind of this thin coating, you can't measure it. And sometimes patients are very asymptomatic and we don't really see anything on the MRI. We only find melanoma cells in the spinal fluid. So very different than brain mets, or if patients have melanoma in the liver and are suffering from that. So different disease burden, different symptoms. And again, still overall poor survival, which makes companies sometimes a little bit hesitant to look into this patient population, even though in my personal humble opinion, this is exactly the patient group that we need to invest and push as hard as we can. We know that the CSF is very different, and we call this a CSF microenvironment compared to the brain by itself, or even the body, again, lung, lymph nodes. So it's very, very different. And again, what we don't know is what patients' immune cells are in the CSF. Can we alter them? Do we need to alter them? How can cells get into the CSF and out of the CSF? Again, we are starting to get more ideas, but still one thing we know for sure, that the CSF, kind of the whole leptomeningeal space, is very different than the rest of the body. And finally, the drugs, right? Most patients, like I mentioned, had been exposed to the drugs that we have available and develop LMD while they are on the current drugs. And so the question is, again, what is the best delivery? Do we need to put it down the spinal fluid? Is it enough to give it by vein or orally? Do we need to push up the dose? So these are things that we're currently investigating, obviously, with our ongoing trials. Again, do we need to put more T cells down there? What is the half-life of the agents? Do we give it into the spinal fluid, for example, and it disappears within, 5 hours? And what about the drug formulations? I can't just crack open a BRAF pill and just put it down the spinal fluid, right? So these are all considerations that we constantly have and constantly try to fine tune and improve. And so I would like to thank you all for your attention. As you can tell, this is an old picture. I had darker hair and longer hair at this point, but this is just part of our amazing team. Some of you might have met. And again, I really want to do a huge shout out to all our amazing patients and their families, their support, their ongoing pushing us to try to find cures and make life for our patients better. And I can really say you inspire all of us on a daily basis. And so thank you again for your attention.